So my name is William van Woensel, and I'm here to present our work on a semantic web framework to computerize stage reflex testing protocols to mitigate the underutilization of pathology tests. And in our particular use case is pituitary disorder. So this talk will be almost aggressively unrelated to machine learning or data science, in contrast to most of the talks today. Not because we don't like those topics. At our research group, we do that work all the time. It is just because this work was much more suited towards a knowledge representation and reasoning approach. And near the end, I will elaborate on why that is. So an introduction, in recent decades, services from clinical biochemical laboratories have grown to include laboratory interventions. So how that works is a PCP or primary care provider requests certain tests from the lab, and then a laboratory clinician or LC interprets those results of those initial tests, and then may themselves proactively add on extra tests to test for certain conditions that they know may occur, and then provide interpretive comments to the primary care provider. So this provides in-house expertise on what in the end are highly specialized domains, such as pituitary disorder, to general care practitioners, and aims to help them in diagnosing illnesses with complex, insidious, and variable onset. So a common use case here is pituitary disorder. Relates to the hormonal system in general. In particular, pituitary is a gland at the base of the brain which produces a number of hormones. So-called cellular masses, so cellular is again a region in the brain, account for 14 to 18% of all brain tumors, and up to 40% of these cellular masses present with hormonal deficiencies. Now, specialists in this field, endocrinologists, right, specialists in the hormonal system, they're well aware of hormonal patterns that are indicative of these cellular masses. However, this is often quite elusive for general care practitioners if there is no red flag hormone level, right? There's no one hormone that sticks out. Rather, it is a complex pattern that falls into place, and that may be indicative of dysfunction. This is often missed. So this makes it a very good use case of laboratory interventions, where a laboratory clinician who is a specialist in pituitary disorders can help the PCP in diagnosing these kinds of dysfunctions. So in and of itself, that's useful, diagnosing dysfunction, but as I mentioned, it can also point towards cellular masses, which can end up being quite harmful to people. So two mechanisms exist really to provide these kinds of laboratory interventions. Reflex protocols are automated. They apply fixed criteria on initial test results and then reflex add-on tests on the patient sample. Reflective protocols are manual. So the LC or the laboratory clinician reflects on the initial test results and then may, based on their own discretion and clinical acumen, manually add on tests on the patient sample. So in prior work, we actually combined these two mechanisms into a single protocol. We had a reflex mechanism that retained initial test results based on certain criteria, and then a reflective process commenced. We found a higher incidence of pituitary dysfunction than the state of the art. We identified 24 cases of pituitary dysfunction that would have otherwise been overlooked. So it was quite successful in that regard. So if you look at reflective protocols, these tend to issue far fewer add-on tests onto the patient's sample compared to reflex protocols, and yield similar or even higher accuracy. So issuing fewer tests means you have a lower marginal test cost, right? So the cost of adding on a test onto the patient sample, and you have fewer false positives because these tests come with a false positive rate. It seems that the reason for this is that the LC, the lab clinician, often goes on this line of reasoning and this thought process that involves manually looking up information from a hospital laboratory information system, and based on that, they make choices that are not easily computerizable. It's also quite difficult technically to tie a reflex protocol into those information systems, so they have access to all that information. So long story short, reflective protocols seem to be more economic and higher or same accuracy. However, they are very time consuming for the laboratory clinician, and we know this because of our prior work. Our laboratory clinician took about 112 hours over the course of a year Even in a combined reflex-reflective protocol, where a reflex protocol took the brunt of the work actually to retain initial test results. This has associated salary implications, right? This may sound a bit cynical, but financial factors will invariably enter into organizational decision-making, right? Spending so much money on relatively rare dysfunctions, right, may not be deemed too wise. I mean, here we say 24 cases of pituitary dysfunction is a huge success for this kind of work. But in the grand scheme of things, it is almost insignificant, right? You could spend that money on buying a new MRI machine or something that impacts more patients. So this high cost calls into question the feasibility of laboratory interventions using a reflective or even a combined reflex-reflective protocol. So we present a semantic web framework for computerizing reflex protocols, which are fully automated, do not include a laboratory clinician. And we aim for these protocols to be economic, more economic than the state of the art. And also we want them to be an interpretable method for adding on tests on that patient sample and providing laboratory interventions in general. This framework allows computerizing these kinds of protocols for different clinical domains. So in our case, we target pituitary dysfunction, but you can apply these to other cases where lab interventions are useful. Firstly, we aim to improve the economic aspect by supporting staged reflex protocols, where tests in stage N are only issued when certain patterns are found in tests in the prior stage. And I will give an example of that later on. This aims to avoid redundant add-on tests while still casting a wide enough net to catch all relevant pituitary dysfunctions. Secondly, we aim to generate interpretive comments for the general practitioner, which is typically not done by reflex protocols. This is something a reflective protocol would do, right? These are based on the initial and the add-on test results. And the goal of this is really to delegate a degree of reflection to the requesting physician. We no longer have an LC to reflect, so we delegate that to the general practitioner, who that comment is supposed to empower them to practice their own clinical acumen to determine whether this is pituitary dysfunction, and even allow for a degree of learning by the general practitioner by providing this comment and explaining why we may think that this may or not be pituitary dysfunction. So in particular, our framework involves the reflex ontology. This includes concepts, description logic concepts, and domain agnostic swirl rules for implementing these reflex protocols. And then criteria that are specific to a clinical domain are then represented as domain-specific swirl rules. So they're kind of inserted into this reflex ontology. So our prior combined reflex reflective protocol fit into the following kind of pathway. Firstly, as I mentioned, a reflex action retains certain initial test results based on fixed criteria. And here you see some example criteria. FD4 hormone is below a certain value, the TSH hormone is below a certain value. And these are then simply retained for perusal by the laboratory clinician. In the second step, I won't elaborate on, the LC simply excludes patients under a specialist physician or an endocrinologist. We assume that they know what they're doing. We're not going to bug them with our interpretive comments. The third action here, the LC excludes patients with known reasons for the abnormality. For instance, if they're on thyroid medication or non-thyroidal illness, that may explain these particular hormonal values. So again, we don't bother with the interpretive comments and with the follow-up. Then finally, the LC may add on additional endocrine laboratory tests. And this is based on their own discretion, on their interpretation of the results based on information they may find in hospital and laboratory information systems. These, here in the first row, the third column, list all possible tests that could possibly be relevant here, right? And typically, the LC would select a subset of these based on what they find about this patient. So if female, we add FSH and or estradiol. If male, we add LH, FSH, TST, so tests for these particular hormones. And then these add-on tests, well, they're performed, the results come back, and then based on the outcome of these tests, the LC may issue an interpretive comment and do a follow-up with a general practitioner who requested the initial test. For instance, if the patient was female over 55 years of age and the FSE hormone was under 15, this may indicate pituitary dysfunction. So they would reach out to the general practitioner with an interpretive comment. If there is a significant dysfunction, then they would literally pick up the phone and call the general practitioner. There's something seriously wrong with your patient. So as I mentioned, the LC will issue a subset of these tests. Very rarely would you see records where all these tests are added. However, a fully reflexive protocol, well, they don't have access to that information that the LC has access to, right? They do not peruse the hospital and laboratory information systems. For instance, seeing prior hormone trends may explain these particular results. This or that illness or medication may explain that particular result. So just to be able to catch all possible pituitary disorder, they need to issue all these tests, right? FSH plus E2 if they're female. If male, they need to add tests for these 3 hormones and so on. So they do not really practice that same discretion as the LC does in a reflective protocol. So as I mentioned, our first approach here was to introduce several stages in these reflex protocols to make them more economic. So in our prior slide, we had the third column here, just to show that, which included all reflective tests, right? So in staged reflex protocol, we subdivide that 1/3 column into these 3 columns. So we subdivide that into two stages in our case. You can add on an arbitrary number of stages. So here in the second row, for instance, you see the stage 1 here, we add estradiol as an add-on test onto the initial patient sample. So before, we needed to add 4 tests onto it, right? Right, so as you see here in the second row, third column, we needed a bunch of tests. Instead, we first have, we stratify this into a first stage, and only if estradiol is low, that may point to a problem. So only then do we add tests for TSH and FT4 hormones, cortisol and prolactin. So in case E2 is not low, we can avoid having to issue these 4 additional tests. And secondly, our approach was to have the reflex protocol also issue interpretive comments. As I mentioned, this was meant to delegate reflective elements to the general practitioner, help them better act on a suggested referral. The goal here is really to reduce the impact of false positives, right? Even with that staged approach, we find that a reflex protocol still issues many more add-on tests. And invariably, this will result in a lot of false positives. So we want to help the general practitioner make sense of the results. So we issue this interpretive comments that help them make sense of it and hopefully even have a learning aspect for the practitioner. These are not automatically generated. They were manually crafted by the laboratory clinician. So in our use case, we had these comments very carefully crafted. In other use cases, I can imagine these could be automatically generated based on the rules that led to a particular follow-up, but that is not the case currently. So a little bit about the Reflex Ontology. We created it using OWL2DL and Swirl, semantic approved language. So it's executable by any semantic reasoner supporting these technologies. It's interoperable with biomedical ontologies and their particular taxonomies if that is needed. So a health condition is associated with a particular or 1 or more reflex rules. So in our case, we have 12 or 14 reflex rules. So in case that reflex rule meets certain domain-specific criteria on the patient, then we infer that this reflex rule reflexes on that patient, right? We infer the predicate reflex on. Then we look at the exclusion rules of that reflex rule, right? So we have this inference, right? Reflex rule reflexes on a patient. Not that reflex rule has a number of exclusion rules associated with it. Again, if this exclusion rule has domain-specific criteria that are met, then we infer that this patient is excluded as per this exclusion rule. For instance, they have a non-thyroidal illness or they're on thyroid medication, right? So how about the test patterns and the follow-ups? So similar to before, we have a reflex rule that was reflexed, right, on the patient. That reflex rule in this case has a number of test pattern rules, which are a staged rule. So we'll start with first case where the test pattern rule is the first stage, right? It's not second, third, fourth, it's the first stage. So that's enough here. I'll talk about case B later on. And in case that test pattern has certain domain-specific criteria that are met, then we infer that this test pattern rule adds on certain tests onto the patient, right? And our ontology includes which particular laboratory tests need to be added onto the patient sample. But then I will give examples of the domain-specific criteria later on. So how about follow-up? So how do we trigger additional stages? That's with follow-up rules. So again, we have a reflex rule that was reflexed on a patient. That reflex rule has a certain set of follow-up rules. Again, that follow-up rule meets certain domain-specific criteria. Then we infer that this follow-up rule issues a follow-up on the particular patient. And that follow-up rule can have an interpretive comment. And I exemplified some of those on the prior slide. So now we have a stage 1 test pattern rule that was fired. So some tests were added on. And then we had a follow-up rule that determined, okay, for instance, this test is within a certain problematic range. For instance, estradiol is low. Right? That's the stage we're at currently. At that point, we start looking at subsequent stages, right? Test patterns in subsequent stages. So we look at criterion B here. So in this case, we had a follow-up rule related to the same reflex rule that was inferred. So it was positive, and it was at a stage prior to this test pattern rule, right? So in that case, and the test pattern rule meets certain domain-specific criteria, again, this test pattern rule will infer that some tests will need to be added on as per this test rule. And again, this test pattern rule will have a bunch of laboratory tests associated with it, right? So at this point, we have a stage 1 test pattern rule that was fired, added on some tests, a follow-up rule that checked these tests and turned out they were in the problematic range. So we proceeded to the second stage, where again, we inferred that some tests needed to be added on. So let's look at some domain-specific criteria here. We need to.
William, I have to ask you to come to the conclusion because we are a little bit late.
Okay, no worries. So for domain-specific criteria, we simply need to make sure that they're applied on the appropriate tests. That's more of the details. So below here, you see 2 example domain-specific criteria. We have a test of type FT4, so tested for hormone FT4 has a certain outcome, so then it meets a certain domain-specific criteria. We have a test for TSH. Again, the outcome is in a certain range, so again, it meets a second domain-specific criteria. In case those 2 criteria were met, then the reflex rule would fire. And similar for the 2 test follow-up example there. So with regards to accuracy, wasn't quite as accurate as the reflective protocol. So we based ourselves on the study records of the prospective study. We extracted data from it and then ran our algorithm on that. 92% of cases, our tests matched the added on tests from the reflective protocol. 90% of cases are follow-ups matched. The reflex protocol still significantly increases the number of add-on tests. Unfortunately, the staged protocol does reduce this significantly compared to the non-staged one, so it does solve that problem to an extent. So while the reflex protocol yields a much higher marginal test cost, this is almost a moot point because the LC salary is really the largest contributing factor to the total cost, as you can see here, right? So you have a cost savings of 82 to 85% by the reflex protocol compared to the original. So yeah, just going to rush through this here. So, well, I just mentioned this here. So the staged aspect of it does seem to to help quite a lot in reducing the number of tests and hence reduce false positives and marginal test cost. And you also need to consider the cost of implementing a fully automated protocol in clinical practice, the development costs, security audit, training, the use of the system, and so on. Future work, we need to improve the reflex protocol accuracy. We aim to tie in a reflex protocol into LIS and HIS, so information systems, which is typically not done in the state of the art, but we feel if they have access to the same information as the LC, they will perform much better. And that brings us to why machine learning and data science was not really useful here. We simply did not have the information available to infer rules from. The study notes that our experiment was based on did not actually include that information that they based themselves on. It says for one initial test result, we issue an add-on test for the exact same test result for a different patient. We don't do that. We have no idea why. The LC went on some tangent in their head, looked up on information systems, all sorts of stuff, and they determined it wasn't needed. So we don't really know. So there's no real opportunity for data mining here. And we aim for a 12-month prospective study of the reflex protocol. So it can, well, it's better than a retrospective evaluation for sure. And hopefully we'll get more insight into our approach. Thank you very much for your attention. Sorry, I'm over time.